our existing CA Bridge followers. We're happy that you're here. Welcome to the movement. We're here. We're building a treatment access network, and you are part of that success. So our success is your success and vice versa, right? We're here to support each other, and we'll make low barrier medication for addiction treatment available in every community in California. I welcome our new addition to the CA Bridge team, Cheryl Ann. Cheryl Ann is in charge of these wonderful collaboratives. She's a project manager, and she'll be supporting the team in all of the coordination for our new network as well. And Cheryl Ann comes with us with lots of experience. She has dealt in the CalAIM Enhanced Care Management and community supports. She has extensive history with her background includes public health training and substance use prevention. And so we're really glad to have her in charge of our collaboratives. So this is kind of the handoff to Cheryl Ann. You'll be with her today. So we're really excited to have her. Of course, I'm Sherry Cisneros. I'm the Navigator Program Director. We are as you know, CA Bridge is a program of the Public Health Institute's Bridge Center, and we receive support from the California Department of Health Care Services. So we are happy to have you be affiliated also with you and our big family, our Bridge family, and we're all under the umbrella of Public Health Institute. So welcome. Share your name, your organization, what city or county that you're in the chat. We want to know who's in the room. So good morning, Tamara. I see all of these wonderful greetings. So we're so happy to have you. So please put that in the chat. Our agenda today, we're going to just do a brief overview of CA Bridge. If you're new to us, you're like, who is CA Bridge? Well, I'll let you know. We have our Deputy Division Chief Marlise Perez from DHCS. She'll be talking about the Behavioral Health Services Act, and the follow-up will be with Dr. Andrew Hearing from CA Bridge. We also will have a navigator story. So we're going to end with the breakout sessions, and like, if you're not ready and you can't come on screen, that's okay. As long as you could type in the chat, that would be great. But if you're on a phone and you can't do neither, that's okay too. We are glad you're here. So just forewarning you about the breakout session, you will be asked to join and participate. But if not, we totally understand. And then we'll wrap it up. Cheryl Ann will wrap it up with announcements. All right, learning objectives for CEU learners today. And if we will be giving out CEUs for CADAP, CCAP, and Cal Mesa peer support specialists. These are the learning objectives. Our quick intro to CA Bridge. You know that we are statewide, and our goal is 24/7 rapid access to substance use navigation and addiction treatment across California. And we know you are the biggest part of CA Bridge, so we thank you again for being here today. Our model is very simple. It's always been a three-prong approach. CA Bridge is revolutionizing the system of care with low barrier treatment, connection to care and community, and culture of harm reduction. That is our model. Very, very simple. And we're so glad that so many hospitals throughout California have adopted that program. Now, without any more announcements to make, we have Marlise Perez, has been the division chief with the California Department of Healthcare Services since 2013 and the state level in behavioral health since 2001. So she is the subject matter expert today on all things behavioral health with the state of California. Marlise is the project executive and DHCS lead for behavioral health transformation. That's what she's talking about today. And she leads the Community Services Division, which is in charge with the policy development, oversight, compliance, and monitoring of approximately $10 billion in behavioral health prevention and harm reduction treatment, recovery services, housing, and infrastructure projects and services. She is Ms. Perez is also California's single state authority on substance use disorders for the Substance Abuse and Mental Health Services Administration. She holds her bachelor's in international relations and has a master's degree in organizational management. And Marlise, we are honored to have you here today and share some time with us to talk about all of the things that are happening at DHCS with this behavioral health transformation. I give it to Marlise.
Thank you so much. I'm really excited to be here with you today. And I'm going to present to you a little bit about some of the changes that have been happening with the passage of Proposition 1, but also known as Behavioral Health Services Act. And I'm going to leave time for questions because I know sometimes I'm talking at a level that maybe you're not as familiar with. So any kind of question when we get to that part, super happy to answer and help you learn a little bit more about this effort. So we can go to the next slide. And so what I want to focus on today, I just chose a few key places of the Behavioral Health Services Act that I felt would be most pertinent to you folks and the work that you do. However, it is much broader than what I'm even discussing with you today, but I'll leave you with some information if you're interested in learning more about some of the other areas as well. All right, next slide. So behavioral health transformation is really the effort that we are lifting up at DHCS around the passage of Proposition 1. So Proposition 1 passed last March, and it really revolutionized how we have behavioral health services, the accountability with them, the transparency, how our county partners and providers really not only enact some of the services, especially those services that come from the Mental Health Services Act, but also how folks can really see how these funds are planned at the local level and then also expended. And so there's really two big portions of what I'm just going to shorthand call BHT, but Behavioral Health Transformation. One is the Behavioral Health Services Act, and that's really what I'm going to focus on today. But I did want to mention the Behavioral Health Bond really quickly. And so what the bond is over $6 billion and a little over $4 billion DHCS is overseeing. And this is really bricks and mortar treatment facilities for mental health and substance use disorders. We just recently awarded $3.3 billion. And then as of last Friday, actually, we just put out our request for application for our second round of funding, which is a little bit over $800 million. So anyway, if that in any way touches your area that you're interested in either expanding a current facility or starting one up for mental health or substance use disorders, this is your chance to jump into that as well. All right, next slide. So just really quick, some of the milestones, like I've mentioned, the proposition passed in 2024. However, there's many different provisions that come into play throughout the next few years. There is really, I think the main thing I'd want you to walk away with when we're talking about the Behavioral Health Services Act is that really takes the Mental Health Services Act that was passed over 20 years ago. That was Proposition 63, and it really changes up how those funds are expended at the local level. And that's why I really want to deep dive into a few spaces where I think will be really important for the work that you do. We have been, because it's such extensive legislation, it was over 200 pages alone, we have been putting out our policy via a policy manual. So you don't have to look for all of our information notices. Anything pertaining to behavioral health transformation is in the policy manual. I know some of you have already been commenting on that, so really appreciate that because some of those big pieces of that came out at the end of 24. We finalized some of those into 25, but we're going to continue to roll those out throughout 2025 or any time that we have policy related to this topic. We're going to spend a lot of time today talking about this integrated plan, so I'm not going to go too far into that. But the integrated plan is just really a tool for our county partners to provide us their information on how they're lifting up all these changes. Next slide. So as I was mentioning, if you are familiar with the Mental Health Services Act, that is, and if you're not, just really quick, it's sometimes known as the millionaire's tax. So in California, anybody that makes over $1 million has a tax, and that comes into providing what used to be just mental health services, but now has been broadened out to behavioral health services. So with the change in legislation, it changes how that funding comes, not how it comes to the counties, that the mechanism is still the same, but how the counties are to expend these funds. One thing I do want to note that it's not that it created new funding. The counties have been utilizing this funding, like I mentioned, for the last 20 years. What it does is it changes the focus of where that funding is to be expended. And so just want to briefly mention 30% of that funding is now around housing interventions. So that basically means an individual that qualifies for BHSA, so whether they have a mental health or SUD, and they meet those qualifications, and of course then either are at risk of homelessness or homeless or chronically homeless, lots more information around all those eligibility requirements. But then they can receive housing services, and that could be interim through an interim setting. But really what we're looking for here is in that permanent supportive housing kind of setting to really help an individual get into that level of housing. So I'm not going to speak about that today, but just want to make sure that you're aware of that. I am going to talk a little bit about the full service partnership. And that is, if you're familiar with that, kind of the whatever it takes, really wrapping around that individual for the services that they need. And so I'll spend some time on that. And then the last bucket is really a bucket that has a big focus on early intervention services, also outreach and engagement, some workforce. There is some funding there also for capital facilities and technology. And this is also where a lot of our county partners use this funding as a match for Medi-Cal services. So that bucket, not going to talk about as well, but if any of these, the housing interventions or the BHSS interest you, we already have our guidance out on both of those. They're actually in chapter 7 of the policy manual, so you can read more information about there as well. Next slide. All right, so just wanted to have this slide in for you back to the bond here. One other thing I do want to mention, I talked a little bit about the DHCS bond funding that we are having, already awarded, like I said, about 3/4 of it, and then the other fourth that we have the request for application out. But do just want to quickly mention there is up to $2 billion also that is being led out by our partners at the Housing and Community Development Department, and this is through Home Key Plus. So if any of you are familiar with the Home Key model, and this is basically setting up some housing infrastructure, the actual, once again, kind of bricks and mortar. But this housing is dedicated for individuals with behavioral health needs. So really excited about this work. This money is also going out. So if you work with any housing partners or you know of anybody that you connect with, this is a great opportunity for them. It's a rolling basis, so they haven't missed out, but to connect them to that. Next slide. So I already mentioned that we've awarded the $3.3 billion. If you're interested to see maybe from in your county who received an award, on one of my last slides, I have links to our website, but it is through our Beach It program. And then if you are someone that maybe applied and didn't receive an award, we did receive up to almost $9 billion in applications, and we had only a little over $3 billion to award. So don't be discouraged. You can always put your application back in. We are going to be hosting a webinar in the next few months about some of the reasons applications weren't funded. One of the largest is we only had $3 billion out of 9 that asked for awards, but also you really have to ensure that you're expanding behavioral health services. This is not funding to preserve any of the activities that you're already doing. So this that slide there did just mention really quick that RFA did go out on Friday, so that is live. So if you are interested, when I made this slide, I wasn't sure if this presentation was gonna, which day it was gonna be announced, but anyway, that is live and available now if you're interested in more of that information. Next slide. So I already mentioned this. We did award over 124 projects, but that is actually expanding 214 facilities. Some of these are relatively small facilities, and some have anywhere from I think we have one that we awarded up to 9 different licensure types in mental health and SUD on the same campus. So having these large campus models that have that full continuum of care. So these really range. So I just want to encourage you, if you're a small mom and pop, we fund those as much as we do other facility types as well. Next slide. This is just a quick breakdown if you're interested in how we made those awards. We also have a lot of other information on our website that really details out the awards that we made. Next slide. All right, so this is where I really want to spend some of my time today, is really talking to you about this county integrated plan and the whole community planning process, and then how you can get involved, especially hopefully after today. If you weren't aware of some of the changes in BHSA, just want to help you be made aware of that, so where you might want to dive in a little bit deeper at your local level. Next slide. So the 3-year plan, I'm just going to call it the integrated plan. But if you are um, maybe currently locally, you're familiar with the MHSA, there is a 3-year plan. So what this does is this really broadens this out, and maybe you're not familiar with this. But it is really a planning process where the counties over this 3-year period. So this first plan is from fiscal year 2026 to 2029. They plan out how they're going to utilize the behavioral health funding that they receive at the local level. So what's very different about this integrated plan now is it's not just this MHSA dollar, or what is now known as BHSA. It's also all their SAMHSA dollars, their realignment, all of their Medi-Cal. So it really is going to give at that local level. And you'll see it's going to be across for mental health, the care continuum, and also the substance use disorder care continuum. But for the locals to really see, once again, where counties are placing those funds. I do just want to encourage you. It's a lot of information. Like was mentioned earlier, I've been at this work since 2001, and I don't even know everything there is to know about behavioral health funding. So, this really is going to be transformative, but it also is a tremendous amount of information. So this isn't a one and done. These 3-year plans are going to be required every year until maybe the proposition changes, the voters choose something else, but it's already been in place 20 years. But just want you to know, don't give up. It's a lot to learn, but it's really going to, I think, be critical for partners like yourselves to understand the different funding sources and the different restrictions around those as well. And so next slide. Oh, excuse me. So with this integrated plan, oh no, you can go to the next slide. Thank you. So this is really, once again, as I mentioned, a look at how local county partners are, planning to expend funds across these care continuum. It really is going to be providing more transparency and accountability, not only at the local level, but at the state level as well. We will be posting all of these plans. Of course, we'll be reviewing them, working with our county partners. There's also phase 1 performance measures that you'll be seeing that the counties are going to be, working toward, and those are around mental health and SUD. So lots of different data, lots of different information is going to be compiled in this planning process. Next slide. So one of the big changes in this movement from MHSA to BHSA is there are a lot more stakeholders that need to be involved in that local planning process. It's called the community planning process. And so you're going to notice if once again you are familiar with this planning process, some of these key stakeholders that are new to the table, that is a requirement, are expanded around substance use disorders. You're also going to see there's having more stakeholders representing different areas around the BHSA funding. You're going to see those around education, health plans, social services, housing. There's also for marginalized communities, you're going to see folks, just representatives that are really looking at those underserved, whether it's racially or ethnic diverse communities, and of course, individuals with lived experience as well. Next slide. This is the list of the key stakeholders that need to be involved in that local planning process. I do want to highlight, depending on who is on the phone here today, but you could be representing whether it's the healthcare organizations, including hospitals, healthcare service plans. There's also emergency medical services. Let's see here. I was thinking there was one other as well. But if you're not on this list, that doesn't mean that you can't be a part of this process as well. These are the key stakeholder groups that the counties are required to have at the table. So, next slide. There's also, if you are familiar with local planning efforts, there's also different groups that are planning services at the local level. These are the local health jurisdictions. So if you're part of that process or familiar with that, also our managed care plans are required to do a population needs assessment. If you have never heard of this, don't be overwhelmed by this at all. The main piece I'd like you to walk away from today is what we're looking at, because our partners at Department of Public Health and then DHCS, not only from the behavioral health lens, but from another look in, has responsibility to oversee these processes that they occur at the local level. And we've been all working together to join them up with the integrated plan. So there can be more of a integrated, I would say, local planning process that happens with counties. Now, you're also going to see not everything is the same in this kind of little diagram I have here, but you're going to see that overlap there, that there is definite overlap. So really we want to ensure that with these different responsibilities and funding sources, that at the local level, there's this coordination as well. Where this is really going to come into play is we're going to have the stars are kind of aligning with the timeframes and requirements, is really going to be more for that second integrated plan. This first integrated plan, just because of all the different due dates, it doesn't line up as well, but it will be in alignment for that second integrated plan. Now, once again, if you've never heard of any of this, please don't stress about this. I just wanted to speak to this if you're already engaging in this locally. Next slide. This just has a little bit more around that alignment that I just spoke about. So once again, this is more of the devil in the detail that I wanted to provide in case you are involved in this locally now. Next slide. This is so for the integrated plan, so our county partners are actually right now starting initial parts of the community planning process. We have provided the majority of the guidance that they need from the department around the policy, around those 3 buckets of funding that I spoke about, but other requirements as well. All of that is what I spoke about earlier in that policy manual. They are also, we have had out to comment the template that our county partners are going to have to submit to the department. That's been out for public comment. We're going to be finalizing that at the first part of July, if not a little bit sooner. All of that's going to be built into an IT solution where the counties are going to submit that integrated plan to the department. You'll see here they have to submit that draft of that full plan to the department by March 31st of 2026. And then they have to have that final plan submitted to us in June of that they're undertaking. Like I mentioned, some of the counties are already starting, so some of their local community planning processes. So I would just say, as you're working with your county partners, you might want to kind of connect in with them as to when they're going to start that planning process, so you can be a part of that and be ready for that when they begin. As I mentioned, some have started. We haven't heard of that many, so I don't want you to think you've missed out on anything yet, but I would connect with them locally just to kind of get some timing around when they plan to do that. Next slide. This is just some more information about that planning process, what they have to do in order to get that submitted to us at the department level. Next slide. Just more details, once again, around some of the deadlines. I just wanted you to be aware of them so you can make sure that you're engaging before, because once it gets to some of these later deadlines, not that you can't provide input, but really much more of it's going to be happening, I would say, in late summer and fall for our county partners. Next slide. All right, so next thing I want to talk about, and we can go to the next slide. So one of the biggest changes to the Mental Health Services Act is allowing substance use disorder treatment services for individuals, what we call is just only for individuals, not just co-occurring, because right now co-occurring services are allowed, but this is for an individual that has just a substance use disorder. So this is a big change in the BHSA. You'll see here I put in the definition of substance use disorder, which includes harm reduction, treatment, recovery services, and including FDA-approved medications, which I know to our partners here are extremely important. And myself as well. Next slide. So once again, I'm not going to go through all these. All of these are in our policy manual if you want to have more information about what does it mean around substance use disorder, what do these definitions mean. Just have some examples around harm reduction. I know you all are very familiar with harm reduction services, so I wanted to include this as well. You can move to the next slide. Um, I also have a few slides here of ways that counties can be using the BHSA to provide SUD services. You'll see here a few things that we're going to be looking at the state level is when we're looking at that integrated plan, how are they using their funding around substance use disorder services, and not only behavioral health services, but their opioid settlement, their SAMHSA dollars, all of those funding services as well. We're going to be looking, they're going to need to address the SUD disparities in their integrated plan across those funding sources. And then for our two counties, Napa and Los Angeles, have separate mental health and SUD departments. They're actually going to have to submit one coordinated plan. So we can see for those counties how they're spending those funds across those care continuums. Next slide. So also, once again, this is really detailed. So for some of you, I apologize if it's too in the weeds. But as I mentioned before, Behavioral Health Service Act funding can be used as that federal match for behavioral health services. So that will obviously extend to substance use disorder services as well. And then also, as I kind of mentioned already, they can be used for that harm reduction definition that was stated earlier, recovery services, and once again, a lot more detail is in that policy manual if you want to learn more about that. Next slide. So with here, once again, as I mentioned, it can be BHSA funds can be used to treat SUD only. It can also be used, those three buckets that I mentioned earlier can be used all across those buckets. So just as an example, an individual that has an SUD, only a severe SUD, they can also receive housing intervention funds. So they could have that housing covered with those BHSA dollars. And so once again, they could be using Behavioral Health Services Act funds to support the SUD treatment, recovery, whatever is needed for that individual, or in a combination of these other funding sources as well. And this is a great slide to kind of show you at the bottom here of the different funding sources that our counties receive. All of these are going to be included in that integrated plan that I keep talking about, where they have to explain to us how they're using those funding sources. Next slide. So on this slide here, and one of the requirements that I wanted to call out to you, that when they're providing SUD treatment services, it's very clear in our guidance, they must provide all forms of FDA-approved medications for addiction treatment. And then also, they can use this funding to either assess whether a person has a SUD and treat the individual prior to the diagnosis of a SUD. And then, of course, as I've mentioned, they're going to have to be describing to us how they're providing the SUD treatment services in the integrated plan. Next slide. All right, I feel like I'm going really fast like an auctioneer, and I apologize, but I'm just trying to shove you with as much information as possible. So I just want to ground us back to those 3 buckets of funding. Now I'm going to move us to the full service partnership. This is that whatever it takes kind of model. So as it pertains to substance use disorders, one of the expectations under full service partnership is that they have to have assertive field-based initiation. I'm going to talk a lot about what that means. And so they have to be there's other full service partnership. You're going to see if you go and read that part of the manual, there's levels of care. There's all kinds of other services that can be provided. Counties are not required to have, under those levels of care, specific levels for substance use disorder, but they can. It's not prohibitive as well. But what is required is this assertive field-based initiation. So I want to spend some time in that space. Next slide. So this here is, as I was mentioning, that full service partnership continuum. I just really wanted to show you some of the required services and allowable services. And mind you, this we would go way down the rabbit hole. So I apologize, I don't have enough time to kind of walk you through all of these today, but I did want you to be aware of those. You are going to see here on the right-hand column, though, as I mentioned, they are allowed to have primary SUD full service partnerships. And we do have some counties that have that model that just have full service partnership services or even levels of care for individuals just with a substance use disorder. Next slide. There's also there's levels of care for adults that are identified, but for youth, there isn't a levels of care. We are actually using high fidelity RAP. We don't have a ton of guidance on high fidelity RAP yet because we're actually working on high fidelity RAP with our Medi-Cal benefit. So once that benefit is established, we're going to have alignment with our full service partnership as well. But just wanted to highlight that in case you work with kids and are familiar with high fidelity RAP or kind of in that space with social services. Next slide. All right, so I do want to talk about, you're doing great, whoever's moving the slides, thank you, the assertive field-based initiation. So we can go to the next slide. So once again, this is required for all counties to have this as a part of their full service partnership model. And so this is really, I wanted to make sure I had the definition here for you. So you'll see here in this bottom box, the definition is outreach, engagement, and initiation of medications for addiction treatment in any low barrier setting, such as on the street, in homeless encampments, and in hospital emergency departments to reach people wherever they are. So I know very well, Edie Bridge. I've been a part of working with you folks, Calbridge, Edie Bridge. I've been from the start, love the work that you folks do, as others do at the department. So I really want you to know you fit in here. This is not that you don't fit in other spaces, but you definitely fit in this space here. So I'm going to move us to the next slide. There is a whole section on field-based initiation, but I did want to give you a little bit more detail about some of the why and help you maybe piece this out a little bit better. But really, it is to have this no wrong door approach to connect folks with MAT. And so you'll see here, these are just some of the design principles that we put in place. You're going to see these are very familiar, hopefully to you and the work that you do. But really the ultimate goal for our department is to really increase access to MAT across California, to continue to. We've made a lot of progress and strides forward in California, and we still have a ways to go. So really hoping that this is another push forward that can be utilized by our county partners. Next slide. So there's different field-based initiation models here. You're going to see right here having MAT initiated in the ED. Wanted to highlight that because of CA Bridge. But this is right in our guidance. You're going to see there's other pieces here as well. And I know there's some pilots that have been going through CA Bridge that are noted as well. You're going to see some work around street medicine and other models. So what we're really working on with our counties, we recognize that, well, we have a lot of our counties have CA Bridge in their settings, and we've been doing a lot of work in getting sustainability around that, especially with the community health work and other work that's being done across the state. This is yet again another lever that counties can utilize to increase access and funding that they can use in that space. Next slide. Okay, great. So let's stop here for just 1 second. I do just want to walk you through this. No, I'm sorry. If we could go to the resources slide, and then I'll open it up for questions. But I do want to make sure you know where you can get information. There is our website that we have, of course, and this is just the link there. That's going to actually get you right to that policy manual that I've been talking about. And that also is going to have where we have all of our most up-to-date information. We are also hosting public listening sessions. Our next public listening session won't be for probably a few months, but it's going to be more around monitoring and oversight and some evidence-based practice work. But you can keep an eye on there if you're interested in as those pop up. Of course, there's any questions and feedback. We have an inbox there that you can click on. And then we're also adding more around our technical assistance. We did just post for our county partners a whole guide on engaging folks in the community planning process that may or may not be something you want to check out there as well. So great place to keep in touch with us and to just see what's coming out. As the counties submit their integrated plans to us and we approve those will also be posted on our website, reports, dashboards, more and more information will be posted as we get that information more into 2026, and probably more the latter end of 2026 in the sense of that county look in the integrated plan. But once again, I would just peek in here every once in a while. But with that, I did really well. I got us to 9:38 to leave us some time for questions. I really want to apologize for all the information, but I'm hoping that some of it stuck with you a little bit, but happy to clarify anything that I spoke about, or even if it was something you're interested in that I didn't speak about, happy to answer those questions as well.
Well, I thank you so much, Marlise. I mean, this is really the first time I saw your slide and you were talking about it. I know while we wait, if anybody has questions, please put them in the chat. But as we wait, I'm from LA County. So, this is huge for us in LA County that they're going to be integrated mental health and substance use because for ever since I've been in this, they've been separated. So that was really news to me. What do you think is the most important thing our SUD professionals and doctors, and what's the most single thing? I know you talked about this. This was a good time for them to get involved at the county level. Is there anything that they should really have as the key takeaway to get involved?
Yeah, and so just super quick about LA County. So there's still going to be their separate departments, but they have to do all the planning and the reporting and everything together. So I don't want to start any rumors on that. They'd be all, what? Yeah, so for those, the most important piece, I mean, there's a few things. I'm sorry, I can't always just give one. I would say, first of all, don't be overwhelmed. You don't have to be a policy wonk like myself to be engaged. But also recognizing that, you know, there isn't new funding, but it's how funding is shifting around in BHSA that I think is really important. So recognizing that. Um, and then also it is going to be a different, like, nobody's had this kind of access in or that transparent look. But that's going to be overwhelming for our county partners as well, because there's going to be so many people that don't understand. There are strings that are attached to these different funding sources. So some of that may be complicated as well. But I would encourage you to, as you're coming to the table, like bringing solutions, like, recognizing and understanding that there is this field-based initiation. This is brand new that the counties have this kind of requirement. I would encourage you to kind of look, or maybe CA Bridge, to kind of look at what we're asking for in that space in the integrated plan. So you kind of are familiar with those questions. So you can maybe help and say, hey, I know you've got this that you need to do. Maybe you're already doing X with them. We could do now X plus Y. And maybe the county partner would say, that's great. I'm not sure I can set it up in 26, but let's put this in our annual update, because counties do update those integrated plans every year. So don't be discouraged if at first they're like, because I'm sure they're very overwhelmed, but I would bring solutions to the table of like, this is what's working. This is what we think we can do to help you with this, because they have so many different things they have to lift up. So that would be what I would do if I was in your shoes, and just be involved in that process and continue to be involved in that process. That would be my recommendation.
Okay, we have a few questions, and that's wonderful, bringing those solutions, because I think sometimes this is all overwhelming, right, for the average person that's seeing patients every day. What suggestions do you have for identifying the right people at the counties who are overseeing this whole stakeholder process? Where would you direct them to go?
It's a really great question. Of course, every county has their behavioral health director. Um, I am unsure at this point if, and that's something maybe we can be looking at, because it's been something I've been trying to think about myself, of try to help at that local level. Right now, each county has what's known as a MHSA coordinator, who typically coordinates the planning process for MHSA funds. So that could be somebody as a contact as well, because they do that. Like they've been doing that for about 20 years. So most likely it's going to be that individual that's coordinating this process as well. And as we find out any information or have any tips or anything like that, we'll post that on our website as well. Because that's been something that's I've been thinking about especially for new partners, not knowing quite how to engage. But the best question, is just to be asking them how to be a part of that BHSA community planning process. And it is all done locally differently, because there's different, partners at the local level. So it's not something the state oversees. But like I said, it is the requirement. So really just making sure you're asking for that BHSA community planning process.
Okay, and I have another question from Renee. As a FQHC that provides robust integrated care that includes SUD services, what can we do more proactive in preparation for BHSA transformation?
Yeah, I think for that, first of all, is just recognizing that if you're doing services for that SUD only, like that could be reimbursed through BHSA. So understanding, I think some of that would be beneficial for you to once again be kind of thinking about what can you help the county with from your lens? What are you doing now, and what is now allowable that maybe wasn't? And seeing if you're able to provide any of that. As an example, the field-based initiation, depending on what you're doing with MAT and the model that you're using. You'll see there's more information than I had time to get into around the SUD field-based initiation, but I'd be encouraging you to see, like, what is happening now? There's so many things converging. Once again, maybe depending on where you're providing these services, I know some of our FQHCs, especially in rural areas, provide a lot of the behavioral health services. Are you able to link up with a mobile crisis around, potentially expanding out with MAT in that space, and then maybe reaching out more into that field base that could be covered under this, you know, SUD initiation. So there's a lot of different paths that are open. I would also just be, really once again kind of looking to seeing, what you're doing now and what it is that you could potentially add in, even if it's not for this first year, but what you could be providing the county in that space. Because once again, you're going to have a different look now too of like, how's the county spending their opioid settlement funds? Opioid settlement funds are SUD only. You can't be using, funds for just mental health within that space, and seeing, where is my county using those funds? Because those funds are coming in from different settlements that continue to happen and will continue to happen. So.
Great, thank you. I know we're waiting for a list. Two people asked, is there any type of list to get to contact their local behavioral health?
Um, well, there's always the list that the CBHDA has, the County Behavioral Health Directors Association. I mean, that has the list of, if you really don't know where to start, that has all the county behavioral health directors' contact information. So that's a great place just as kind of a step one, and that's really updated really frequently. So that's a nice place to begin if you don't have contacts at the local level already. So I would recommend that as a starting point.
Thank you so much, Marlise. It was a lot to cover. We really appreciate, I know, you were making these slides, and it's something that you're just presenting out to us. So thank you for giving us this preview of what's going on with the counties. This is amazing. And we appreciate all your hard work leading this movement. And we will definitely keep in touch with Marlise. So if you did have a question that you didn't get answered, didn't have time, we can definitely connect you. So I thank you very much, Marlise, for all your time. This is such a great, informative presentation. Thank you.
You all, and have a great rest of your day. And thank you so much for the work you're doing. It's just really inspiring. So take care.
Thank you, Marlise.
Bye-bye.
Bye. Next up, hello.
Yes, Sherry. So thank you so much, everyone. I hope you enjoyed our speaker. Marlise gave us a great and very timely information. Again, if you have any questions, I know we couldn't get to them all. I also am getting a list of emails in the chat. This is really great engagement. Go ahead, if you have any questions, make sure to write down that email from this last slide, bhtinfo@dhcs.ca.gov. And so going to our next session, we're going to be talking about rapid MAT expansion. And our next speaker will be Andrew Herring, our founder and one of the founders and principal investigators of CA Bridge. Andrew is an attending emergency physician and associate director of research at the Highland Hospital Alameda Health System in Oakland. He is also the medical director of the hospital's substance use disorder treatment program and attending physician of its interdisciplinary pain medicine program. So without further ado, I will go ahead and give it to Andrew to speak on rapid MAT expansion.
Wonderful. Great. Thank you. Hello, everyone. Okay. So one, I just have to, sorry, this is so funny. Apologies all, but I literally dropped my cell phone on my face as I was lying on the carpet doing a backstretch. So apologies for the black eye. So first of all, I want to just really thank Marlise and all the many, many, many people behind her and in the various divisions of DHCS that are pushing this truly transformative agenda. I mean, there's so many details to it, but this underlying idea that mental health and behavioral health have to come together, this idea that the healthcare providers and behavioral health providers and street-based providers and all these folks need to come together is truly transformational, and is a many years of work are going to go towards actualizing this, so that our patients and the people we know and love that are struggling with substance use disorders can really feel those benefits. So I think the key role that we play at Bridge is just elevating the lived daily experience of someone, in crisis, who has a addiction to opioids and fentanyl, and just to keep bringing it back down to, this is a red hot, out of control emergency. This is something that no one in their worst imaginings would have ever predicted would have happened. The idea that we're here in 2023 and the number one killer of people 45 and under in California is drug overdose. 20, 30 years ago, that would have been unthinkable, right? But it's this new reality. The 2023 numbers have come out, and the overdose rate is not going down, right? We are still at equivalent levels of the peak of the epidemic, of the COVID epidemic. So this is our number one public health problem. These are young people. As an emergency department physician, I take care of all ages and many folks at the very end of life, where much of our healthcare is focused. Yet here, this is this disease that's taking young people, and we just need to be all hands on deck with this incredible sense of mission and purpose to fix this, right? To do everything we possibly can. And for me, that's what Bridge is about. Next slide. The core here is that fentanyl is lethal. It's that simple, right? It is like a loaded gun. Every single time you use, it is an emergency. And it is an opportunity for us to get in there, because every single time someone uses, they are at risk of death. Next slide. We need a crisis plan. This is something that's well described across the literature, where if you're in crisis, you need someone to reach out to who's there when you need them, someone to call, someone who picks up the phone and responds to you during crisis, and a safe place to go. So this is, for me, this is kind of what's behind this idea of assertive field-based MAT, is that we need to move from static services that are available somewhere out there someday to, we are with you, arm in arm, right here, right now, to keep you safe. Next slide. So if we're going to drill back to this public health approach, right, this is our goal. Next slide. Is reducing overdoses. Like, this is this thing that can get lost within 14 things. But this is the issue that just needs to go from this big to just to be this big. It needs to be this broad-based obsession with, there is not futility here. This is a solvable problem. Our overdose rate is absurdly high compared to any other country in the world, any developed country. We can reduce it. We have real tools. We can be successful. Next slide. The first thing is understanding that referral is not an adequate response to a crisis. When you are in crisis, you cannot, apologies. You cannot receive a referral. You need real-time help. And we know this, if someone is at risk of suicide and they call, they aren't given a referral, right? You need immediate help. And that sense that opioid use disorder, that opioid misuse, is something that needs urgent, high quality, medically informed care, is a mindset that's missing, that we need to elevate and deepen. Next slide. Just ask yourself, like right now, if you, or if someone you knew, someone someone you love, a friend, a family, just came to you and said right now, hey, I'm in trouble. I'm buying oxy pills online. I'm buying fentanyl. I'm Where would you send them today where they could be treated, be given real help today? Most of you, I would argue, probably don't have a place to send people. And unfortunately, that's the reality for most. Lots of places where you can find out someplace that you might be able to get into treatment at some point if you meet a criterion or pass some assessment. But just that core understanding that, no, that's not how it works. You need to be able to call and pick up the phone and get someone who actually authentically cares for you and is ready to do whatever it takes to get you out of that crisis spot. That's what we need. Next step. Our next slide. So with great respect, right now, our system has a huge gap. These are the services that are out there for crisis, and I can go through them. Next slide. I love secret shopping and would encourage you all to do this. 988, right? This huge, amazing idea. If you're a crisis, call. This is me pretending to be someone using fentanyl. What happens? The operator does a Google search, and then she finds high barrier methadone. She finds a website they find a website that is not for patients, it's just for clinicians, and then a link that doesn't accept Medi-Cal. Doesn't work. Next slide. 211. I did 211 looking for substance use disorder treatment. It literally sent me to the Immigration and Citizenship Office in a neighboring county. Next slide. Findtreatment.gov. It just gave me a listing for a VA hospital. Next slide. Shatterproof, amazing. It's incredible for categorizing high quality static places that you could go. In this case, in Oakland, it was all methadone folks, right? Which is nothing wrong with methadone, but most of these places actually don't have open access, meaning you can't just walk in, you have to schedule, right? And it's very difficult to get buprenorphine. This doesn't work either. No one to call. Next slide. Choose change. This is a whole static list of doctors, many of whom I know personally, and I know many of whom have left the area, none of whom accept real-time folks to walk in. Next slide. So it should be no surprise that of the 341,000 people who have Medi-Cal, are people who we believe are struggling with opioid addiction, only 23% have access treatment in the last year. Not saying 23% are getting long-term treatment, meaning just have tried it once. So this is only 10 or 11% with methadone and 12% with buprenorphine. Next slide. This is not like, oh, go back, please. So the core thing to understand is that there's nothing inherent to opioid use disorder that means that you don't want treatment. This idea that, oh, yes, they're living with treatment, they're living with the disorder, they're living with opioid misuse, but they're not ready. That is just not true. And it's an incredible, really a very risky assumption to make, because really it lets you off the hook. And we need to feel incredibly pressured. Like our work is just at the beginning. We need to grow massively to meet this need. And we know this because opioids are something that have been with humanity for thousands of years. And around the developed world, most treatment engagement rates are double, triple, quadruple what we have. So again, there's no excuse for how low engagement in treatment is here in California. We must do better. Next slide. What we've done and what we feel really proud of with Bridge is looking at those priorities, a place, someone to call, someone to respond, a safe place to go. Fundamentally, what we created with the emergency department system is a safe place to go. And the more time that passes, the more I just feel so incredibly proud of what everyone in this room has accomplished and how meaningful that is. Because that's just this core thing. You need somewhere to go. And that's what we have with the Bridge. Next slide. We see in these data that we have more and more emergency clinicians prescribing buprenorphine every day. This really blows up the myth that frontline physicians don't want to help. They don't want to be involved in treating substance use disorders. It's not true, right? You provide support, you provide incentives, and people sign up. People want to help. And we see this with this dramatic increase in the number of people seeking care in the ER for buprenorphine and the number of clinicians that are there to help them. Next slide. So this is this core myth, right? So and we just need to really drill this, right? This is the lever, is like, if people say that they don't want treatment, it's just not true. We do the research, we publish it. When we found that you pair, a common sense initiation guideline, like simple, let's go, let's get you started on treatment, with a navigator who doesn't judge you, but is there to provide adaptive, real-time help in any way you need, 85% of the people living with opioid use disorder said, yes, I want to start treatment. This is the fact. This is the real. Don't let the myth throw you off. Next slide. And this is what we saw. You follow them for a year, right? And actually, many people are able to establish the gold standard of engagement and treatment of 6 months of continuous care. So if you start buprenorphine 9 times in the ER, one of those folks is gonna change their life. They're gonna stay in care for 6 months, which is an incredibly high standard. And what we see there is this jump, and this is where Bridge is really making the leap, is you have to go beyond a safe place to go to get started. So, and then move into supporting this continuum of care. Next slide. Navigators are the key, right? This is what ties together this fragmented system. Next slide. This is all kind of what it looks. And this is sort of the future, this idea of Bridge Connect, where we fix this crisis access, right? That we create a place online where you can call, you can text, and you can get connected to this incredible combination of these navigators around the country, around the state, and empowered emergency departments that provide a safe place to go. So we fix this problem, someone to call, someone to respond, and a safe place to go. And then we link this to all the work that Marlise and others are doing to creating this robust continuum of care that's multidisciplinary and meets people where they're at and carries them through, or not carries them, but supports them and takes the journey with them to long-term recovery. Next slide. So this is the Bridge Connect that we're going to be coming out with soon, as we're building the website right now. And it's this idea of just taking off-the-shelf ideas that someone in opioid crisis needs somewhere to call. And we're really looking to all of you here to help us bring life to it and make it part of what it means to be a Californian. That all of us in this room, that everyone in California could answer that core question, that when themselves or someone they love is in trouble, they have somewhere to call. Next slide. Again, drilling us back, fentanyl is lethal, right? Next slide. Referral is not an adequate response. Next slide. Everyone with opiate addiction needs these things. Someone to call, someone to respond, and a safe place to go. Next slide. So the question is your community prepared for this emergency that continues to rage? And how can you move things forward? How can you help? Next slide. Thank you. All right.
Thank you so much, Andrew, for letting us know how we can get involved in rapid MAT expansion. And also, I just wanted to bring back to our model that none of this would be possible without our navigators. And so before we get into our breakouts, we really want to bring it all back together and hearing about how patients are getting help and getting treatment. And so I want to introduce one of our navigator mentors, Jolie Reyna, from navigator at Cedars-Sinai Medical Center. And so Jolie, if you can answer for us, how many years have you been in substance use navigation?
I've been working as a substance use navigator since I'd say September of 2021.
Oh, thank you so much. So it's been about 4 years now. And so we want to hear your story. And go ahead and take it away and share us a story about a patient that you've worked with.
So I help so many people, and it's hard to kind of just come with the the perfect story. So I'm just going to use the most recent or the perfect example of why uh, this program works. So I'm just going to use one of the last people I helped about a week and a half ago. Um, a 49-year-old gentleman came into the emergency department, and a lot of times I don't get consults. I'm searching the track board and just kind of chart finding, but he popped up for me because I saw that he was unhoused and had cellulitis. So I went in to meet with him, and I noticed through the notes that he denied fentanyl use and any drug use to the whole care team. So I went in and I knew he was in a lot of pain, but I just wanted to let him know who I was and just kind of offer him something to drink and see if maybe he'd be willing to talk to me. And he really just wasn't. He shut me out. And so I kind of just put his face sheet to the side and kept him on my radar. And he ended up going to the CDU, which is kind of like a step above the ER. So he was admitted, being administered antibiotics and being offered help through social work and through case management. Um, and I noticed that he kept, and then also our homeless coordinators, and I noticed he kept declining all these offers. So I waited like a couple days, and I noticed that they were giving him medicine, so he wasn't going into withdrawal. It wasn't Suboxone. So I kind of waited for the right moment in the day and went up and spoke with him, and he denied me again. So I said, okay, well maybe I'll just come back and speak with you in the morning. So I tried again on the third day, and he was open to talking with me, and I asked if I could sit down and just see if there's anything I could do to offer him anything. And he said, really the only thing I'm interested in is sober living. And I was like, oh, okay. So there's a great treatment center I work with that takes Medi-Cal. It's called Tarzana Treatment Center, and I really like them. Their patient navigators get back to me really quickly and help me place patients a lot of times same day into detox, sometimes a couple days, but at least they help place patients. We all know how hard that is. So I asked him, why he, because another thing he kept denying starting Suboxone, and he said he had like a pretty traumatic experience with precipitated withdrawal. So I said, okay, well, let's just get you into detox, and they've got, a great team that can induct you, and you'll be in a really good environment. And then eventually it will lead to transitional housing, and they can even do, they can help them like find a job. And I went over everything in detail. So it really helped to know exactly what Tarzana treatment offered, like the counseling and the mental health. Not to mention, he also had like severe trauma and anxiety and depression, and so it was hard for him to kind of get going with other people offering help. But I think really just being persistent, coming in there, sitting down with him, and just taking a little extra time to kind of get to know his story and listen to what he wanted, and then kind of just use that opportunity to offer to rope in detox, because he's just like, all I want is sober living. So I think it ended up being a success, because I did a pre-screen like that day, and the next day he was going to be discharged. So when I spoke with social workers and the case managers, they said he wanted to just go back to the street. So I think that was a big success. Like, not only did he get connected with a really good treatment center that could lead him to housing, it was also a MAT, medic for Suboxone at that clinic, and then also offered a dual diagnosis. So that's what I have to share.
Thank you so much, Joy. That was really impactful.
Yeah.
And it really brings it back to the point of how this model really works. It really works at helping patients and people with opioid use disorder. So thank you so much for your story. And we're going to have a chance now to talk to other people in your region about how we can work towards networking with one another, breaking down the silos to get people talking. As we learn, even though we're working on that integrated process, it's not like that for all regions, and every single county process is different. And so in your region, we want you to be able to connect with other people and to talk about how you can grow this network to get people the care that they need. So thank you all. We're going to get into our breakouts now. Hi, everyone. I know we were cut short. It's because we are actually at time, but I know we were having great conversations. We were actually in the middle of something I will share, and we got cut off because we were asking about how can we support you. And so as CA Bridge, how can we support your counties? How can we support the work that you are doing? And so we will have more of these regional collaboratives. We're having in-person regional collaboratives in your region, and we will have more time together to be having these discussions. And I'm just so glad and thankful that you all made it here to this space today to really share your thoughts and to listen in and learn more about for Marlise and also from Andrew. And also just thank you so much for bringing in your expertise as well. So we'll have more of these. I mentioned our virtual meetings, and in our group before we got cut off, we were mentioning that what would you like to hear in that next one? And so we're open to hearing feedback. And so if you can go ahead, in the next few slides, I'll be showing that eval link. That is a great place for us to get that feedback for the things you couldn't share in the breakout groups today. Please use that as a way for us to get some feedback on what you would like to see for these meetings. Okay. We have in-person regional meetings that are upcoming June 10th in the Central Coast. It will be located in Monterey, so we'd love to see you there if you're in the Central Coast region. I heard in my group there are a couple of folks who are slow. If you're available, it's going to be next Tuesday, June 10th at Oscar's Playground on Cannery Row. So we'd love to see you there. July 9th for Los Angeles and the Ventura region, that's coming up next month, as well as July 25th for the Inland Empire, so Riverside and the Redlands. We have future dates coming. They are going to be announced, but we will come to East Bay, SF, also South Bay, Northern Rural, Orange County, and San Diego and Imperial Valley. We will be in your region, and we will have more chances to talk with one another. So if you have any questions about the regional collaboratives, if you had any questions today, here's a QR code that you can scan with your phone. You can scan with your camera, and we can always send that link in our post-event email as well. And last but not least, please complete our evaluation. As I mentioned, today's event is eligible for 1.5 CEUs for community health workers, TP and CCAP, counselors, and peer support specialists. But this evaluation, feel free to also use it for feedback as well. So again, here are the two different links for that eval. Again, this will be sent out in the post-event evaluation. I know we're a little bit over time, but I do want to share just one more quote. And thank you so much again for attending. And that change will not come if we wait for some other person or some other time. We are the ones that we've been waiting for, and we are the change that we seek. So thank you so much for being here. You are the people who are making that change. Thank you so much for being in the space with us today. And that's all we have, and we hope to see you at our future events.